Now I'd like to introduce our Q&A panel. We have Scott Power from Morgans, we have David Nayagam from Evans and Partners, and Chris Callos from MST Access. So those will be the panelists. We'll start the process with about 15 minutes of Q&A, or maybe 20 minutes of Q&A for Fiona and Mark, and then we might bring Gary in and we can extend the Q&A to more farm access level questions as opposed to just the clinical program. So do you guys want to get started? Perhaps Chris, you're not on mute. Do you want to start with the Q&A?
I can start. Professor Wood, I guess the question for me in the other trial, which is the criteria is quite objective. How do you go about choosing or standardizing scarring? I imagine there are many varieties of skin types and types of scars. How do you go about standardizing that for the purpose of this trial?
We the first 8 patients have all got have got a range of scar, and what we're looking at is the scarring context of that individual. So we are aware of all the pigment load of the individual influences, the time from injury, all these different things are data points that we're capturing, because what we're trying to find out as we go forward is which scar type is actually the most receptive, and the individual variation is actually fundamental for to build that knowledge base. So rather than trying to get everybody with a similar scar, what we're looking at is anyone who has a 10 square centimeter scar and put it into context of that individual. So we're feeling our way forward, and I think that way we will be in a position to understand what patient is the most likely to be responsive. And I think that's a lot of work to do in the future as well, looking at men versus women, age. We know that collagen turnover is slower in older people than in younger people. So is this more effective in younger than older? That kind of thing that will build this knowledge base as we go forward.
I guess the follow-up question to that is, does that become harder with keloid scars?
Keloid scars are harder, full stop. Yeah, and I think we're in a position that, in these particular trials, we are not going for keloids in the first instance. Right. So I can tell you these scars are not keloids, what we're researching, because they are so complex. I think that's an opportunity for the future, but then that will be a separate cohort. Did that be reasonable, wouldn't it, Mark? Because the cellular differences are quite significant.
Yeah, the whole pathophysiology is different. So yes, I think there's definitely potential for 6302 in keloid, but we would have to do that as a separate, distinct trial, not as part of a broader scarring trial.
Sorry, and the third part of the question is, given that we're focusing on established scars, can you perhaps talk about the timeline of the current trial? What are the next steps?
In terms of the current trial, it's we're looking at an improvement over a 3-month period. Mark, do you want to talk about the heavy water which has guided us in that space?
I can talk a little bit. So we have actually done some measures in humans of collagen turnover. So we're pretty confident. So we did this partly to underpin this trial as to whether LOX might be effective in established scars. So we have actually measured collagen turnover in established scars, and some of that is actually in patients who are enrolled in this study. So we'll hopefully be able to kind of look at collagen turnover and how that maps to, whether the treatment's effective in these established scars. Right. I think in terms of the timeline, were you sort of asking more about the timeline of?
Oh, it sounds like you're still, as Professor Wood said, you're feeling your way in terms of the indication. When do you think you'll have a clearer idea of what specific subsegment, when you stratify the scars, where the next steps may be? So what's that sort of time period?
I think sorry, I misunderstood the question. Certainly from already, there is in some quite complex scars, there is an indication of improvement. You could they could feel and see a difference.
Okay.
And so I would anticipate that the putting kilos to one side, we will have my observation is we'll have an impact on scarring. And the time you will apply the cream, for how long, and all those things are what we will be working out. But from a perspective of the scars, at this point, our indication is that they are responsive so I don't think that's the issue. I think it's more of the how long you give it for, and maybe in certain circumstances it requires longer. Yep, that's what and it may need 3 months instead of 2 months, that sort of thing.
Yeah. Can I squeeze one last one in? Obviously, it's early days and we're talking burns and acute settings down the track. But from a conceptual level, can you see a possible combination of this product with, say, something like a RECELL for burn patients?
I think that's an interesting one, because it depends on looking at which patients do require that scar modulation. And certainly at the 6 weeks mark, we would be looking at introducing this as in patients who have had RECELL or more complex reconstruction. Our issue is, can we, in the acute work, start that 4 weeks earlier, so we drive down that upswing? And so yes, we will be looking at this across the board of complexity in our acute work as well.
Great, that's it from me. I'll let someone else have a go. Thank you.
Thanks. Maybe David next.
Hi there. Thank you for both of you lovely presentations. So, I mean, it's been said that the human wound repair is one of the most complex biological processes that occurs during our lifetimes. You know, there's so many finely tuned and timed molecular and cellular pathways involved. It's actually kind of remarkable that the repair process can occur without more malignancies, I think. So just reflecting on, you know, the safety profile of PXS 5505, I'm really interested in your thoughts on how you see this treatment as part of a therapy that targets just one part of that repair process, albeit downstream in the cascade, but just interested in your thoughts on the balance of everything going on.
Can I just start on that one? So you're absolutely right, and largely in terms of sort of therapeutic development for wound healing, people have focused a lot on the actual wound repair itself. And that is an infinitely harder space because there's so much going on, you know, whether it's TGF-beta or CTGF or all these other factors, and the balance of the factors and the inflammation and all the things that happen. So that has really been a really complex challenge. Whereas I think what's nice about this is you don't necessarily need to intervene at that point. This process of collagen remodeling and stability and processing happens pretty much forever. So you can let the wound heal. You know, Fiona can do the surgery and the interventions, and you get the best healing you can, and then you can treat with a LOX inhibitor, right? So you're avoiding that complexity and even the toxicity of a wound environment where a lot of compounds and stuff are probably going to be less effective. And certainly biologicals have been shown to be less effective. So I think what's nice about this is you kind of miss that really complex where there's so many different processes happening simultaneously, and you actually treat it when the scar is actually just really focused on remodeling of the dermis. So yeah, I think it's kind of a more, yeah, it's a better time to intervene because there's a lot less complexity.
Great, thanks. Maybe
That's
Scott.
great.
Scott, do you have any questions? Sorry.
Yeah, thanks, Michael, and thanks, Fiona and Mark. That was a terrific presentation. So just looking at the results which we're likely to get out in late 2022, you'll be having a really good look at some of the efficacy measures in the scar structure. I'm just wondering what a good result looks like You know, we're starting off with a 10 centimeter scar. You know, what would be a good result for you that would make you sort of really impressed and, you know, hopefully move it forward towards a registration?
From my perspective, I think if I kick in there, if the patient thinks it's better and wants to continue using it and try it in other areas, that's success. We spend a lot of time in this space. And as you saw, you know, we kind of, with the silicone pressure gums, all this sort of thing. And if we have a therapy that the patient thinks has improved their scar, then that is the biggest tick we can have, because they're the people that wear it. Having said that, then there's all sorts of other things that we need to look at, whether it's the scanning, and I hand over to Mark to look to respond with respect to histology and all that kind of the structure of the skin, so we can back it up with that sort of thing. But point of fact is, if somebody would continue to use it and then their POSAS, their assessment of their scar has improved, that's our biggest tick. Would that be fair, Mark?
Yep, for sure. And I think just to be clear with this, so we are treating 10 square centimeters, but a lot of these patients have much larger scars. So we are only treating a part of the whole. So it does give an opportunity to really see a difference, because these are established scars and from an appearance perspective are fairly static. You can kind of see the impact of the treatment in the context of the larger scar for a lot of these patients. So I think that gives us an opportunity to see a difference.
Thanks. I guess you're also looking at assessment of more objective assessments as well of the quality of the scar.
Yeah, so that's, Fiona sort of alluded to the 3D scanner. I think that's really good. So being able to measure the volume of the scar over time, I think is really critical. So we'll be starting that with this randomized cohort of actually measuring that in 3D, which will give us a really an objective measure of, you know, how thick and how the contours and stuff of the scar. So that should give us some really nice data around that.
Right.
And just one other question, if I can, just the rationale for using the 2% cream versus the 3% cream, which seemed to perform significantly better than the 1.5% cream.
So we did, in a initial study, we did dose escalating up to 4%, and 2 and 4 looked very similar in terms of their levels of inhibition. And we have actually measured inhibition in these. So one of the reasons I think we were keen to minimize the dose is because then we can treat a large area. So particularly for large burns, you know, some of these patients might have 60–70%. So clearly, if you have, you know, 60% of your body covered in a cream, that's a pretty large dose. So we wanted to minimize, but still obviously get effective inhibition. And we have measured that in this first 8 patients, and we are getting effective inhibition at 2%. So we're happy with that. But yeah, we weren't really concerned in terms of the dose. We could have gone up to 3%, 4% for these smaller areas we're treating, but it was more looking to the future and being able to cover, you know, a whole arm with the cream and not sort of have to worry about the total dose that a patient was receiving. And yeah, as I say, our measures of LOX inhibition look really good. So 2% seems to be just as effective.
A question came up from the audience. So just before I perhaps hand back to David, it's sort of relevant to what you were talking about, Mark, and that's about the safety profile and whether the agents are systemically absorbed, and whether there's a sort of a maximum length of use that you've established is safe.
Yeah, so that's part of obviously this first trial. This will be the longest we've treated. We have had some patients out to 2 months without any issues. Certainly there's no rise in systemic levels with once daily application over 10 square centimeters. So everything we've seen, and obviously we do pathology bloods at every appointment as well, and none of those have shown any kind of indications of systemic changes in, you know, liver or kidney or whatever. So all the data we have at this point would suggest that yes, it's safe and you can do it for a long time, but we'll continue to collect that obviously over the coming kind of 50 patients and be sure that we can sustain that.
Maybe I just jump in there just briefly. So what we're doing now with collection of all this data sets us up for then going to a regulatory body with a and for an IND, so we could go to the FDA with an IND, and we've got a lot of the information now on producing GMP material on the tox that we've already done, and now collecting patient level data. And as you rightly say, Michael, we're looking at the level of systemic exposure to the drug versus what's in the skin. And Mark nailed it. You want to have something which has a biggest safety margin as you can, so that you can use it on as big a skin area as you can, because a lot of these patients do have scars over a much larger area. So that's where we're heading with this. So we should be ready to go back to the FDA with an IND within the next few months, once we've seen data coming out of these first 8 patients that have come from the study.
Great. Thanks, guys. David, over to you.
Thank you. So just, getting back to what you were saying before. So it sounds like, if you think about common traits for scar-free wound healing being rapid reepithelialization, dampened immune system, delayed collagen deposition, and the ability to remodel. And this treatment is really focusing on sort of the latter two, I assume. Is it something that you would then assume that patients will be using for life, or do we get to a stable point? And just bringing that back to the trial, the 3 months. I guess 90 days is where we typically talk about scar syncretization. But is it possible that with the reduction in the collagen matrix formation, you might expect that time might be elongated for scar syncretization? And would you expect there to be a longer term follow-up in these patients, perhaps as an extension on the trial?
Yeah, so that was quite a long question. There's quite a lot of questions, I think, but I'll see what I can remember. In terms of the follow-up, yes, I think we need to follow these up. So at the moment, they're getting treated out to 90 days, and that's their final appointment. But actually, LOX isn't replenished very fast. So even when you stop giving the drug, they don't get LOX activity for quite some time afterwards. So we would imagine that the remodeling will continue for quite some time after you've stopped taking it. So yes, we need to look at these patients a bit further down the track, because they may actually continue to get improvements related to their treatment, even though they've stopped. No, I don't imagine they would need to take this for life. I kind of showed in that slide, shifting that balance. So you would imagine if you shift that balance forever, that potentially would be deleterious, right? You would start to get thinner skin and problems. So you would imagine there's kind of some optimal, and this may be different for different people, and the extent of the scar, but you would imagine there's a point where you would want to stop in that balance. So what we kind of know is the fibroblasts that produce all that collagen are very sensitive to the matrix they sit in. So actually, the stiffer and worse that matrix is, the more they produce. So what you would imagine is, as that matrix gets less stiff and remodeled, they stop producing as much. And we know that happens physically. We don't know that happens in response to LOX inhibition at the moment, but we know that happens, that the fibroblasts respond. So that's kind of how we would hypothesize this, is that the matrix gets remodeled, it gets less stiff, the fibroblasts start to produce less collagen, you reach a new normal, and that's your kind of more supple, more pliable scar tissue that looks much more like the normal skin, and then you stop treatment.
Yeah, that's exactly. So I guess, looking at your stress strain plot, the Young's modulus and the overall yield strength are very comparable. And so what you're saying is that if you were to continue indefinitely, you might see that a growing disparity in those measures. Is that what you, and are you sort of looking for some kind of a steady state where you're avoiding cutis laxa or any other sort of changes?
Yeah, potentially, if you treated indefinitely, you could start to change that stress strain curve. That would absolutely be a possibility. We don't really know is the answer. Would there be a plateau where the body stops responding and just, or responds? So one of the things we did measure quite early on was, we thought, well, if we stop cross-linking of collagen, will the cells just produce more collagen to kind of compensate? And that doesn't actually happen. Certainly it doesn't happen over the short term, in the week or two. So we've tested that in the lab because that was one of our concerns. Whether they would then respond, if the matrix becomes so weak, do they then respond? We don't really know. We haven't got to test that. But I think that would be a really long term, but you might reach a plateau where they respond, or you may just reach a plateau where it doesn't matter whether you keep inhibiting it. Just
can I just add to that as well, from a clinical perspective, where we've got a significant scar, that is not responding, we would sometimes do what we call a Zebplasti. And that means we change the direction of the skin as a Z, and we close it the other way. And in doing so, we change the tension and the mechanobiology of the surface. And in that circumstance, we see the hypertrophic scar resolving, and it usually is between the 6 and 12 weeks we see that response, and it doesn't recur. So I think we have clinical, practical, sort of observational evidence, if you like, that when you change the mechanics of it, of the skin envelope, you can actually then change the phenotype of the cells that are driving it. And so in my head, that's why we're looking at this 3-month time frame. Change something in 3 months, can you keep it changed for life? Can you unscar the scar to that point, and then that be stable? And that's what we're looking for. But it's not coming from out of the blue. That's what I'm trying to say. It's coming from practical observation of what happens when we do more complex things like surgical intervention.
Professor Wood, can I just ask, sorry, David, you go ahead. I think I've jumped in.
No, I was just saying thank you for that good answer. Yeah. Thank you.
Yeah. Professor Wood, can I just get your comment on the experience you've had with the first 8 patients that have gone through the trial? Anything you can sort of pass on to the audience?
I think, sorry, from my observation, sometimes you can see a difference, and it's like, am I wanting to see a difference, or is this real? Yeah, but certainly there are a couple of that first 8 that if I look away and I feel the surface, I can mark the edge. I can feel the edge of the area of treated. Not in all of them. And I say it's very early, and you don't want to say like, whoa, it works, you know, and it's fantastic or anything, but clearly there's something happening. And I can't think of it, so probably half of them at this point, but they're all at different time points because we're going through. But it's really interesting. And then you think, can I feel the surface difference because it's a different cream that's being put on the surface? So that's why the randomized trial is going to be really important. The carrier as well versus the drug as well. Because am I feeling just that kind of moisture change, or am I feeling a real change? And so certainly it's encouraging, but you know, I wouldn't be putting my hat and my coat on that hook yet.
I think the nice thing so far is that also what we're seeing is it's pretty well tolerated. So I mean, the important thing is that we're going to be able to get 3 months data on all these patients, and there are going to be some controls in there. So come the end of the year, when we get around to August, September, hopefully we'll see, you know, in an overall sense. I'd just like to stress the exploratory nature of this as well. I mean, we are throwing Mark and Fiona are looking at all kinds of endpoints and measures and skin types, and they've explained how we're exploring the impact of different types of scars and different pain. This is collecting an awful lot of information that allows us to plan the next stage and go on for it. I think we're all very hopeful that we'll see a positive change in the scars, and then it'll be a question of trying to identify, okay, so which scars in particular should we trial this in? Where should we really go that we can make a difference? Because I think maybe Mark and Fiona can comment, but the history of trying to run clinical trials in scarring is littered with probably trial design problems in trying to control the patient groups and trying to work out, you know, how do you actually measure an effective drug that's going to match what the FDA or the TGA are going to say, okay, yeah, that's a treatment that we're willing to approve.
Right. Perhaps we have probably time for one more question, so I might see whether, Chris, do you have one more question you want to ask of the team before I move to a couple of questions from the audience, and then hand over to sort of questions that might be more pharmaxis related than specifically for Fiona and Mark.
Just the last question around the design of the trial. Now, given the exploratory nature, and powering of the way forward, what kind of strength of data would you need to sort of plan next steps here, given the limited number of patients? But sorry, that's a bit vague, but I guess in terms of getting next steps or getting guidance on where to go to next for the indication, how strong a signal would you be looking for across how many patients of that type?
I think I'd be guided. I mean, Fiona said it earlier on. It's if you've got a significant number of patients saying, "I want to carry on," and it makes a difference. Okay. I think the collaboration between us and the University of Western Australia would be really digging in deep the thing to try and work out, okay, where is that improvement and what makes sense to go next. We've talked a little bit this morning about some of other types of scars. So yeah. One of the biggest probably areas of unmet need is in keloid scarring globally, which occurs mainly in African and Asian skin types, and there's very little that we can do for those patients at the moment. And if the prospect of maybe being able to surgically excise a keloid and then stop it recurring, that would be also an interesting place to go. So I think, yeah, if we can see something happening and we're clearly modifying the scar, we'll be taking puncture so you can count the number of crosslinks in the collagen. So mechanistically, I think we'll know, yes, it's working at that level. And then are we structurally seeing changes in the scarring and are patients noticing it? If that's a yes, then we'll be very encouraged to keep going. I think because it has potential huge benefit for patients.
That's great. Thanks, Gary.
So perhaps I can sort of bring the two questions from the audience together into one, which is really looking forward, and it goes to some of what you were just talking about, Gary, taking what's really a phase 1 into a phase 2 and beyond. What's the sort of the future roadmap here from a phase 2 study and also a regulatory approval process, particularly in Europe and the US, where it doesn't look like there's a predicate treatment to compare to, and you'd obviously have to be going through some kind of potential pivotal trial. So perhaps just at a high level, talk through what, subject to success in the trials going ahead with Fiona and Mark at the moment, what future development pathway looks like for this.
Yeah, so certainly the next these two trials that we're talking about, I don't remember there's another one after this looking at patients with burn injuries. Those two trials would generate a significant amount of data, and with that, my hope is that we'll be able to go to a regulatory agency, TGA, FDA, EMA, and talk about patient selection and endpoints that they would see as being enough to give us an approval. So the next trial design really has to have a heavy regulatory input into it in terms of angling it towards what do regulators need to see. I think I know what myself and Mark and Fiona would like to see. We just if the patients say it works, it's worked. That, however, doesn't always tick all the boxes for the regulators. So we need to really consult with them. But the beauty of what we're doing now is generating data that allows us to have a really good scientific based, evidence-based discussion with them, as opposed to 9 out of 10 cats liked this one, so that's what we're going to do kind of thing. It really gives us that huge ability to do that. So as I mentioned, we'll be probably having an initial what we call a pre-IND discussion with the FDA once we've got the data from the first 8 patients and the safety information that allows us to go there. And then that develops into a full IND for a specific clinical trial application once we've got the data from all the patients going through. And that'll be an exciting step forward, which should happen towards the end of the year.
Great, thanks, Gary. I guess at that point, it's probably a nice segue into any more Pharmaxis specific or general questions around the agenda that we've worked through today. So maybe David, or do you have any more general questions for Gary before we?
Sure. Yeah, I could ask one. So it's really interesting stuff. I mean, the idea of reducing fibrous capsule development around a medical implant in my former life is actually a serious issue too. And I just wondered, because obviously there's implications for electrode tissue interface, signal to noise ratios. impedances, all of these different things. There's a huge industry built up around that, and some of them involve slow release of various drugs, whatnot. Have you considered other applications of this technology? It's, for example, a slow release formulation that could be used with implants.
We haven't yet. I think we see this as proof of concept, and if we're really making a difference, then it obviously opens up a lot. We've had surgeons come to us and talk about the post-surgical closing of surgical wounds and the adhesions that they get inside them in abdominal surgery and things like that, which all could be potentially targets for a topical LOX, which is maybe putting an implant or is a spray that you do before you close the wound. I think there's a number of different ways we're going. So we'll be certainly inviting Mark and Fiona to come with us and talk to professionals from other walks of life to sort of look at the data that's coming out and the scientific understanding of what we're actually doing to see the applications in other areas. So I don't want to get ahead of ourselves. I think we just need to see data from this and then explore. But clearly, there's a lot of opportunity there. Yes.
Related to that, I think it was mentioned earlier that there is quite a durable inhibition to the LOX from the drug. About how long do you see, or is there evidence about how long you see that duration extend for beyond the application of the drug?
I think the nice thing, from Mark maybe had a comment on this, but one of the concerns we had was, you're applying something which is reducing cross-links in collagen in the scarring process. So if a patient then is on the drug and then has an injury and needs to go in for surgery, what do you do? And I think the nice thing is that once you stop treatment, the actual inhibition of the enzyme within the skin, it drops off pretty quickly. So you're not going to interfere in wound healing for a repeat injury that's going on. So that's one of the safety issues we have to look at. Mark, would that be fair?
Sort of. So the inhibition does last for a while because LOX isn't synthesized very quickly. So because it's an irreversible inhibitor, once you actually prevent LOX, there's not a sort of uptake of an upswing of LOX expression. So it will be in the weeks, I think, post taking LOX inhibition that you actually get full LOX activity. You get restoration of some activity fairly quickly, but full restoration of activity will be in the weeks post your last dose, I think.
But from that perspective, it's not functionally active in the early parts of wound healing, yeah? So we still get those early phases of wound healing. Anyway.
It would also be very different if you had a wound because your body will synthesize a whole lot of LOX as part of the wound healing process. So I'm talking about its restoration of activity in an established scar, which is obviously a very different context.
Great, thanks. I think we've got just enough time for maybe one or two more questions. So maybe Chris, do you have something for Gary generally?
Finding the mute button. I think most of my questions have been answered. In terms of, sorry, Gary, in terms of on the financial side, in terms of funding, future funding for similar programs, what's the capacity for Pharmaxis to expand the clinical trial program into, say, topical?
Yeah, so we're funded to get to data in the current study and the myelofibrosis study that are ongoing. So once we see data from those, then the company would have options in terms of looking at collaborations with other industrial partners or going back to the markets again as well. So I think in our Chris, in biotech, we're driven by data at the end of the day. I think if you look at our valuation at the moment, it doesn't really reflect where we are as a company in terms of the clinical development trials we have ongoing. But the data changes that. So we're funded through to data, and that fundamentally changes the perspective of the market on us.
Yeah, no, great. Thanks, Gary.
All right, maybe one last question from Scott, and then
thanks, Michael. Professor Woods, you were fairly clear with your timelines in terms of the recruitment for the trial. That was my observation of the way you presented the data, or the way the trial is panning out. So was my observation correct that you don't have an issue with the recruiting the patients for the next 42?
I think the next 42 are a different group, and so we've gone to a public expression of interest. We have people approaching us by email all the time, trying to because things that they hear about what we're doing, and so our original 8 are very much more intensive, and they were screened very rigorously, and we did put the onus of a lot of biopsies and a lot of blood tests on them. So they were a group that are very vested. And I think that going forward in the next 42, the impost on that next 42 patients is a lot less. And so I don't perceive that I don't anticipate any issues, because there is a lot of people out there with scarring. I think the only thing is that scar's got to be big enough for 10 square centimeters and as a minimum. And so we will see in this next 42, there won't be just our burns patients who are well known to us. There'll be a much broader group of people.
Thank you.
Great. Thank you, Dr. Wood or Professor Wood and Dr. Fear. Gary, did you want to make any closing comments before we close this briefing session?
No, just to thank Mark and Fiona for sparing some of their valuable time to share. We at Pharmaxis, we live on our collaborations in effect, and I think we're really grateful that the science attracts scientists of these caliber to come and work with us. We couldn't do anything without them. So thank you both very much.
Great, and thank you to David, Scott, and Chris for your time and questions, which hopefully have served to inform the participants on this call. And as with the call on Tuesday, I understand after a couple of days, this will also be posted on the IR part of Pharmaxis's website for future people, for future reference, or other people that weren't able to participate in the entire thing or at all. So thank you very much, everyone. With that, I'd like to draw the session to a close.
Thanks, Michael.
Thanks, guys.